Hello everyone, welcome back to my channel of lively life snippets, living every moment to the fullest. Today I made my PRP case report into a video. My case report was derived from a patient whom I met during my 1-week respiratory (MTAC) attachment with my preceptor. The title is a case of off-target mild asthma control, to choose short-acting beta-2 agonists SABA-only or short-acting beta-2 agonists inhaled corticosteroids LABA-ICS therapy. Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please speak to your doctor and healthcare team. This video is a sample of case reports that I had done during my provisionally registered pharmacist PRP training in Malaysia.
The format of case report heavily depended on your preceptor. Kindly consult him or her. For my case, no abstract or introduction was needed. So, let's proceed to case presentation. A 38-year-old Malay woman was referred to respiratory medication therapy adherence clinic for worsening, off-target asthma control and newly started metered dose inhaler (MDI) beclomethasone 200 mcg twice daily on the 17th of April 2019. She had been taking cough syrup daily lately. She claimed she had been using MDI salbutamol almost daily and nebulized in private clinic for 5 times since January 2019. She was presented with productive cough for 2 weeks in January 2019 and hence referred to cough clinic to rule out pulmonary tuberculosis. Patient claimed having asthma since childhood. Her mother had an asthma history. She had underlying diabetes and hyperlipidemia. She was prescribed salbutamol metered dose inhaler (MDI) 200 microgram when needed, metformin tablets 1 gram twice daily, gliclazide tablets 160 milligrams twice daily and simvastatin tablets 20 milligrams at night. The random blood glucose (RBS) level recorded on the date of visit was 13.8 millimole per liter. HbA1c of this patient had risen dramatically from 6.5% to 9.9% over 6 months from October 2018 to April 2019. This coincided with the timeframe when the patient was having exacerbations requiring nebulizations. She worked as a teacher in government school which utilized blackboard and chalk. Dusts from chalk triggered her asthma. Sudden changes in temperature from air-conditioned office to room temperature classrooms, flights of stairs and slope from car park to office often made her short of breath. She led a sedentary lifestyle with little to no exercise, as exercise made her breathless too. Her BMI was 33.87 kilograms per meter square, obesity stage 1. She was a non-smoker, denied drinking alcoholic beverages or any recreational drug use. She was married with 2 children and stayed with family. Upon assessment, patient showed satisfactory MDI techniques. Patient did not exhale fully before dose actuation. After counseling, patient demonstrated good techniques on second attempt. Overall, patient scored 8 points out of 25 points for asthma control test. This showed off-target asthma control. For the past month, she had applied 2 days sick leave due to asthmatic attacks. In view of off-target asthma control, doctor had started patient on MDI beclomethasone 200 mcg twice daily as preventer inhaler and requested patient to keep an asthma diary. Spirometry appointment would be scheduled too. Patient was counseled about the pathophysiology of asthma as well as indication of both preventer and reliever. Importance of compliance to MDI beclomethasone was emphasized. Patient was counseled to rinse mouth after using preventer inhaler. Patient was advised to set alarm to ensure preventer inhaler was used on time. Besides, patient claimed using 1 puff of reliever inhaler only when having asthmatic attacks instead of 2 puffs. Consequently, patient went to private clinic for nebulization. Patient was counseled to use 2 puffs when needed. Patient was also counseled about trigger factors avoidance. Comorbidities worsened respiratory symptoms, led to flare-ups and low quality of life. 1 Relevant comorbidities identified in this patient were obesity and diabetes. In view of high RBS and HbA1c values, dietary advices were given. 2 In next visit on the 7th of March 2019, weight loss program with twice weekly strength and aerobic exercises would be discussed. Asthma diary, medication understanding, adherence, inhaler techniques, effects of trigger factors avoidance and asthma control will be reviewed.
Now, let's proceed to discussion section. Global Initiative for Asthma, GINA 2019 guideline no longer recommends the use SABA-only treatment in patients with mild asthma. Instead, the recommended options are as below: mild asthma, as needed low-dose ICS formoterol, or if not available, low-dose ICS taken whenever SABA is taken, or regular ICS or ICS LABA every day, plus as needed SABA or maintenance and reliever treatment with ICS formoterol, with reliever being low-dose budesonide formoterol or beclomethasone formoterol. Off-label, evidence only with budesonide formoterol, off-label, combination or separate inhalers. The is because asthma is associated with airway inflammation even in patients who experience intermittent or infrequent symptoms. Regular use of SABA augment airway inflammation and allergic responses. Overusage, i.e. at least 3 canisters dispensed in a year, is linked to a higher risk of severe exacerbations, while dispensing of at least 12 canisters in a year is associated with greater risk of asthma-related death. Another disadvantage is tolerance might develop rapidly with regular use, more than once daily, of SABA for exercise-induced bronchoconstriction. If the latest 2019 recommendations is to be implemented locally, 4 challenges needs to be addressed. The first challenge is poor ICS adherence, particularly in mild asthmatic patients with low symptom burden. Compliance to ICS is of paramount importance because it takes 2 to 3 weeks before maximum benefit is observed. Patients who lack of insight may refuse to comply. This will inevitably lead to medication wastage, poor asthma control and over time, severe exacerbation. The second challenge is combination inhalers are much more costly compared to SABA-only inhaler, except the price of MDI fluticasone and evohaler salmeterol 25 mcg, dose and fluticasone propionate 125 mcg, dose. Despite the cost advantage, these evohalers are being listed as *, which necessitate initiation by relevant specialists in hospital. 7 The impact on budget must be taken into account as the price of inhalers per patient can possibly double. The third challenge is at the moment, no data available to demonstrate the safety and efficacy of combining ICS formoterol with maintenance treatment without formoterol. Hence, currently, all patients who need combination treatment need to be given a formoterol-containing combination licensed for both maintenance and relief. In Malaysia, only 2 inhalers which are listed in MO formulary fulfill this requirement, which are turbohaler budesonide 160 mcg per dose and formoterol 4.5 mcg per dose and MDI beclomethasone 100 mcg per dose and formoterol 6 mcg per dose. Therefore, limited choice of therapies is a challenge. The fourth challenge is the role of ICS beta agonist therapy in circumstances for which SABA-only treatment is currently used, that is, acute severe asthma, has to be reassessed. For our patient, option 2 was adopted. If asthma control deteriorates, dose of MDI beclomethasone may be increased before considering to switch to appropriate devices containing ICS formoterol.
As a conclusion, replacing SABA with fast-acting LABA-ICS as reliever therapy reduces asthma exacerbation risk. However, the recommendations need to be adapted according to financial resources available, local practices as well as patients' preferences and clinical responses. Here are a list of references that I had used. Feel free to further study them for more information. Thank you for watching Lively Life Snippets, and if you like my videos, hit the like and share button. Don't forget to subscribe and see you all in the next episode.